So with that, I'm going to kick things off. Thank you for joining everyone today. My name is Matt Kelly, and I'm the Research Program Manager of the BC Brain Wellness Program. And today we have a very exciting topic looking at the A to Z's of sleep and brain health. We have three fantastic speakers today, all coming from UBC, so it's a homegrown crowd today. Our first speaker is Dr. Ryan Falk, who is the postdoctoral fellow in the Department of Physical Therapy at UBC. He has studied under the supervision of Dr. Teresa Lou Ambrose previously, and his research examines how physical activity, sedentary behavior, and sleep can impact the cognitive health of older adults and people at risk of dementia. Our second speaker is Dr. Jason Valerio, and Dr. Valerio is a clinical scientist at the Pacific Parkinson's Research Center, and he is the first neurologist in Canada with a subspecialization in sleep and movement disorders. So please welcome Dr. Valerio. And our last speaker is Elaine Book. Elaine is a clinical social worker at the Pacific Parkinson's Research Center at UBC. She was also involved with the Parkinson's Disease Foundation, World Parkinson's Congress, and is an integral member of the BC Brain Wellness team. So please welcome Elaine. So with that, I'm going to pass it off to Dr. Valerio, who is going to kick things off for us. And he's going to start with his talk. So we'll pass the microphone off to him.
Welcome to Wellness Wednesday on this beautiful sunny day to learn a little bit more about sleep. So my topic was sleep in neurological conditions, and it's a pretty large topic. So we'll kind of just cover the most important or most pertinent topics. And the outline for my talk. So we'll start with why humans sleep. We spend 1/3 of our lives in this activity, so we should at least have some understanding of why it actually happens. Then we'll go on to a little bit of sleep physiology very briefly, and this is relevant for management of some sleep problems. And then we'll talk about some common sleep problems in neurological diseases and in the general population. Things like insomnia and circadian rhythm dysfunction happens quite often in neurological diseases. Excessive daytime sleepiness can happen because of brain diseases, but it can also be secondary to a brain pathology. Then some complex nocturnal behaviors, which can happen in some diseases. And we'll touch on all of those. So why do we sleep? Well, there's a multitude of reasons why humans sleep, as far as we are understanding it to this point. One is we know at night during deep sleep, we secrete growth hormone. And so to build muscle and tissue and repair tissue, you need growth hormone, very important. Bodybuilders are well aware of this. Another thing that happens at night, typically during deep sleep as well, is immunomodulatory function or strengthening of your immune system. I actually just received my COVID vaccine this morning. So hoping that I'm going to get a couple of nights of good sleep so I can build those antibodies. A couple of other things that happen during deep sleep, there's different types of memory that you develop. So semantic memory is memory about facts, numbers, and new concepts, or who's the president of the United States, those types of concepts. Those are all facts, and that's all consolidated at night. And then motor memory is consolidated during a different stage of sleep. So if you learn a new skill, like playing the piano or playing a new sport or some fine motor skills, all of that is better developed. And there's some evidence that actually if you sleep after learning a skill, it may actually be better than just continually training that skill itself. A couple of other really interesting things that are relevant to the brain when we sleep there's this concept called dendritic pruning. So if you think of neurons like a tree, essentially there's some pruning that happens at night so that the connections are strengthened, but also a little bit more direct. We know that that happens at night. And then the last one that's probably most relevant to neurodegenerative diseases is this concept of taking out the garbage. So we know that there's proteins that build up in the brain over time as we age. And these proteins are associated with things like Alzheimer's disease, Parkinsonism, and other forms of neurodegenerative disease. And so we know at night is actually one of the only times that you're clearing out some of this buildup of these proteins. So once again, sleep is incredibly important. And then we'll touch on sleep physiology. So there's two concepts here I think that are at least important to kind of have a decent understanding of. There's two things that drive our sleep. One is this S cycle. And what happens here is the longer we're awake for, there's a chemical in our body that builds and builds and builds. And when we fall asleep, it drops off. And then the next day, it builds and builds and builds again, and then it drops off. And so you continue these cycles in about a 24-hour cycle, if you're lucky. If you don't fall asleep, this chemical will build and build and build. And eventually, the chemical is so high that you will fall asleep. You have no choice. I have a picture of coffee here because the mechanism of caffeine is actually blocking one of these chemicals, which is interesting. The second thing that, or driver of sleep, is the circadian rhythm. So we have all heard of the circadian rhythm, and it runs at about a 24.2-hour clock, and it operates kind of in the background of everything else. And this is driven by sunlight or bright light. So that's why it's really important to regulate our circadian rhythm with sunlight, but also there's some relevancy here in terms of using electronic devices at night and how we can sometimes disrupt our sleep with bright lights within a 24-hour cycle. All right, so now let's talk about some sleep pathologies. And again, as mentioned, these are common to neurodegenerative diseases, neurological diseases, but also very common in society. So up to 30% of people will experience at least one form of acute insomnia at some stage in their life, and numbers may actually even be higher than this. Probably up to 50% of people with neurological disease, depending on the type of neurodegenerative disease. So insomnia is actually a difficulty getting to sleep or staying asleep, or even waking up too early. So all of this has to be combined with a disturbance in your daytime functioning. So some people have different levels of sleep time. Some are short sleepers, some just happen to wake up earlier. And if it doesn't disrupt their daytime function, then it wouldn't be considered a disorder. So it has to, again, disrupt your daytime function to be considered insomnia. This is broken up into acute and chronic insomnia. And it is the most common sleep disorder in neurological diseases, as I mentioned. The thing I like to combine, or the other pathology I like to combine with insomnia, because the treatment is similar or they overlap, is a circadian rhythm disorder. As we talked about, all our bodies run on this 24-hour clock. But this 24-hour clock in some people can actually be disrupted. And that can happen for various reasons. When our eyesight becomes poor, we have less light exposure. Or if we have brain disease, we can actually have a dysregulation in the hormones and chemicals that we secrete, like melatonin. And for example, this is seen in Parkinsonism, where there's a disruption in the melatonin production. And one of the more common circadian rhythm disorders as we get older and as the brain ages is actually this irregular sleep-wake disorder. And so this figure here is showing a 14-day cycle of somebody's sleep pattern. So the black squiggly lines essentially are the movement that the person has. The flat lines are when the person's quiet. So what you would expect, so this is nighttime here in gray. What you'd expect is quiet, nice straight line throughout this nighttime period, and then movement all the way through the day. But with an irregular sleep-wake cycle, this person has awake here, sleep here, awake here, sleep. And so they're very fragmented. So if you look on this 14-day pattern, they're completely disrupted. Their sleep is everywhere, and it's short periods of sleep or short chunks of sleep. And this is something that can be modified, but this is seen much more commonly in Alzheimer's disease, other neurodegenerative diseases, and even head trauma. So just something important to recognize if people in your family with neurological disease are having very fragmented or disrupted sleep. And so how do we treat insomnia as well as circadian rhythm disorders? Well, routine is really important. And if we're just looking at sleep hygiene strategies, I think Elaine may touch on some of this a little bit later, but exercise is one of the best ways of managing insomnia, fatiguing the body so that you're driving or increasing those sleep factors. Bright light exposure at a set time. And this is probably my favorite and most recommended management for insomnia. So you have to pick a set time 7 days a week, whether if you're a morning person or a lark, it can be 7 or 8 a.m. And you expose yourself to bright sunlight every day at that time. And sometimes in BC, especially in the winter, it becomes a little bit more difficult with our rainy days. But on days like today, or even using artificial light in the winter can be valuable at a set time or fixed time every single day. That really helps entrain our circadian rhythm, and it helps treat circadian rhythm disruption as well as assisting with insomnia. Another big problem that we see is people take their problems to bed. So there's, we know increased anxiety in society right now with the pandemic and a lot of other issues that are happening. But a lot of times people use that period of time when they first lie down in bed, or periods of time at night or overnight, to just think about the problems or to kind of review the day. And one of the most important things is to actually break that habit. So if you feel anxious, you can write down some of your thoughts, but you do it outside the bedroom. You do it in another room. The more frequent you do it in bed at night, you're going to develop a pattern, and this habitual pattern is more difficult to break, but it will contribute to insomnia. You also want to sleep in a quiet, cold, dark environment. Cold is important. People sleep better when it's a little bit colder. And another little trick is to take a hot shower before you go to sleep. And that helps drive that change in your body temperature from warm to cold. And regular meals, don't go to bed hungry. And usually I suggest proteinaceous meals rather than kind of carbohydrates. You also don't want to eat too close to bed. And you definitely don't want to eat while you're in bed or throughout the night. It really does disrupt your kind of sleep patterns. A couple of other strategies we use, and this overlaps a little bit with sleep hygiene, but it's something called cognitive behavioral therapy for insomnia. And it is essentially retraining of your sleep. It's becoming reacquainted with the bed as a sleep environment. So you want to avoid any behaviors in bed other than sleep or sex. You want to lie down only when you're sleepy at night. And then, of course, waking up at a fixed wake-up time 7 days a week is really important. If you can't fall asleep after 15 or 20 minutes, you can try to get up and do something monotonous or boring in another room, and then re-engage in sleep again when you start feeling sleepy. And again, what you're trying to do is really train the brain and body that when you're lying in bed, all you're doing is sleeping. And sometimes that means actually restricting your time in bed or limiting your time in bed, because you would rather be lying in bed for 7 hours and sleeping for 6.5 than lying in bed for 10 hours and only sleeping for 4 hours. And you want to break those habits of kind of lying in bed for prolonged periods of time without sleeping. So that's one of the best strategies for insomnia. Rarely do we ever have to use medications to manage insomnia if people are able to implement a lot of these strategies. The other big sleep dysfunction or disorder we see in people with neurological or neurodegenerative disease is excessive daytime sleepiness. There's many neurological diseases themselves that can cause sleepiness. So narcolepsy itself is a primary brain disease, but it's obviously a disease of sleepiness. We know patients with MS, Parkinson's disease, head trauma, even psychiatric disease like depression have much higher rates of daytime sleepiness and fatigue. And it is most commonly associated with sleep deprivation in our society. We see high rates of sleep apnea as well that can cause sleepiness, and then medication side effects or medications themselves. And so how do we treat excessive daytime sleepiness? Well, once again, exercise is on the list. Exercise is, again, really important as a fatigue counteracting measure. We also can do things like social engagement. It's easy to stay alert when we're speaking with other people. We always want to review the medications that people are taking. And if something's sedating and they need the medication, then they could take it at night rather than during the day. And if something's alerting, they would take that medication during the day. And sometimes you can actually get rid of some medications if they are too soporific or causing too much sleepiness. You obviously want to treat any sleep pathologies such as sleep apnea and improve your sleep hygiene and your nocturnal sleep overall. And then finally, if needed, again, last resort is using medications. And there's different stimulants that we can use that are safe in neurological diseases. And then caffeine is actually another good option that we can use if needed. And this takes us to our third sleep pathology topic. These are behaviors at night, and there's a whole host of different behaviors, but the one I'm most interested in that I spend a lot of time focusing on is something called REM behavior disorder. This is where people act out their dreams. There's a little video here of this gentleman during his sleep study. So you see him kicking out, you see him striking out, and it is in response to dreams because he's in dream sleep. And obviously you wouldn't want to be his bed partner or you want to manage this. But this is a very common entity that we see in people with Parkinsonism, and there's several different forms of Parkinsonism that carry this type of pattern at night, but it's also seen in other neurological diseases, but more rarely. And another movement disorder at night that is a bit more common is periodic limb movement. And I have a video here to kind of give you an example. So this is typically a flexion response or a little bit of a flick of the foot, and it can be right or left foot or both. And this can infrequently lead to arousals or disruption in your sleep. And this is oftentimes associated with restless leg syndrome. And restless leg syndrome is actually a symptom of feeling discomfort in the legs and the urge to move the legs before sleep. So periodic limb movements typically happen when you're asleep. Restless legs are a feeling you have before you fall asleep. And these are seen much more commonly in patients with spinal cord disease, in peripheral nerve disease, or even lumbar spine disease. And finally, other things that can disrupt people's sleep at night. Overactive bladder is very common as we get older. And in neurodegenerative diseases, we know that people have increased urinary frequency. And so the overactive bladder can become a problem. So how do we manage these things? Well, REM behavior disorder, like I mentioned, occurs more often in Parkinsonism. We first start with bedroom safety. That's the most important thing, removing all dangerous objects from the bedroom, making sure the bed is low in case somebody is to fall. You want to fall out of bed. You want to make sure that they're not hitting a hard surface. You want to remove nightstands away from the tables and all sharp corners. Nightstands have become my enemy since I've started studying RBD. And so I've seen a lot of injuries, unfortunately, from that. So it is definitely something that you want to remove from the bedroom. And if needed, once again, after bedroom safety, melatonin can be used to treat REM behavior disorder, and clonazepam is also an agent in the right patient population that can be used. Periodic limb movement, we rarely need to treat with medications, but if required and it's causing a lot of arousals, we can consider treating it. Sometimes if there's an underlying nerve disease, we can simply treat that. And restless legs, oftentimes, if it is causing disruption in your sleep, you would use medication to treat. And then finally, nocturia or frequent urination at night can be managed both with conservative measures, decreasing your water intake, or medications if need be at night. I didn't get into all the different types of medication that can be used for all these diseases, but this was just an overview. And I think that concludes my talk, but I think we'll have time for some questions at the end. Is that right, Matt?
Yeah, that's correct, Dr. Valerio. Thank you very much for that talk. So there's actually a couple questions. We have a few minutes, so I'll go through the two questions that I have for you right now. Just bear with me. I'm just going to pull them up. So the first question is there a specific type of light that is needed to replace the natural sunlight? And I think this is specifically relevant for our winter times here in Vancouver and in BC. Is there a specific wavelength that needs to be looked for?
Not necessarily wavelength. Blue light obviously is the most important to replace this, but actually it is a very good question. You typically want around 10,000 lux of
I think we're might be dealing
there's a
with a
big
little bit of
spectrum.
a. Sorry, Dr. Valerio, we lost you there for a second. There's a little bit of a glitch in the connection. If you could just repeat what you were saying.
Oh, sorry about that. Yeah, so I was saying that in terms of the wavelength of light, you'd want blue light if possible, but it's less important the wavelength and it's more important the strength of the light. So we measure it in lux, that's LUX is kind of the strength. So usually you want 10,000 or more if you're trying to reset the circadian rhythm. The sun can be anywhere from 3,000 to up to 100,000, but 10,000 is bright light lamps you can buy at the stores. They're also used for seasonal affective disorder. They're called SAD lamps or SAD lamps. So those are always good things to help retrain your circadian rhythm, especially in the winter. So that's a really good question.
Excellent. And in follow up to that, how long do you need that light exposure for? Is there a specific amount of time?
So there's a different protocol for seasonal affective disorder. I don't use that protocol. I actually have my own protocol, which I suggest 15 minutes of exposure of the light. So we're just replicating the sunlight, but I don't want you staring right at the light. So you just want to do something active in the area of the light. So usually I suggest getting up in the morning at the same time every day, having that light on, and then doing some light stretching or something in the vicinity of that light. Again, trying to replicate the sunlight. But there's no perfect protocol, but usually a 15-minute exposure is, should be enough to reset the circadian rhythm.
Excellent. I have a little bit of a longer question here, a two-part question. It's somewhat of a chicken or the egg. Some have the impression that sleep patterns are symptoms of brain diseases. Has there been any work done to show that sleep patterns and disorders other than sleep conditions contribute to the degenerative nature of some brain diseases? And in follow-up, do you think solving some of these sleep problems in patients suffering from neurodegenerative diseases may help alleviate the conditions?
I don't think I fully understand the question, but I think they're alluding to the fact that can sleep dysfunction lead to brain diseases? So there's some research looking at insomnia and how there are higher rates of neurodegenerative disease in insomnia, and that has been shown. And so we have made a push over the last several years to focus on sleep and sleep hygiene, and just for the general public. Sleep deprivation, I think, is a major issue, and trying to optimize and ensure you're getting 6 to 9 hours of sleep each night to reduce the rates of those other pathologies, including other neurodegenerative processes. But I think that's what the question was getting at.
Excellent. That's great. I'm going to pass the mic over to Dr. Falk here to speak a little bit about his topic. And again, we might have some time at the end to answer some other questions, so please feel free to add them into the chat. I'll also note that this session is being recorded, so we are not going to necessarily share the specific slides, but a recording of this, including all the talks and questions, will be added onto our YouTube channel and on our website for future reference. So without further ado, I'll pass it off to Dr. Falk, please.
Okay, thank you everybody for attending here today. I'm excited to share with you some of the work that we're currently doing within the Aging, Mobility, and Cognitive Neuroscience Laboratory in which I work. Just before I get going, I would like to mention and acknowledge that with gratitude that I live, work, and play on the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, and also the Tsleil-Waututh nations. And then also just as a heads up, I do have my dog who's whining in the background, so I apologize if you do hear him from time to time. He apparently decided that this is the exact time to annoy me is when I'm doing a presentation. So apologies if you do see him in the frame or if you hear him whining anytime during this presentation. So with that being said, the general outline for what I'm going to be talking about today is first I'll be giving an overview of the dynamic relationships of physical activity and sleep with cognitive health, and how these two behaviors can interact to impact our cognitive health in multiple different conditions or neurological conditions, I should say. Then I'll be going over two specific studies that we've done within our laboratory. First, a study that was looking at whether physical activity promotion can improve sleep in older adults with mild cognitive impairment. And then secondly, I'll be talking about a recent study we've conducted looking at whether exercise training can promote sleep in older adults with chronic stroke. So I'm sure, as most of us are aware, our cognitive abilities change as we get older, and we start to see some declines in terms of our cognitive abilities starting in approximately the third decade of life. And usually there are slow declines in terms of our memory and our executive functions and things like that as we get older. However, for some individuals, we'll see greater declines than expected for age and education levels, something which is termed mild cognitive impairment. In addition, it's important to note that with mild cognitive impairment, that increases the risk of dementia quite substantially, with about 20% of all individuals who have mild cognitive impairment ending up being diagnosed with dementia within within a 5-year time span. Whereas individuals without mild cognitive impairment, only about 1 to 2% of those individuals of the same age will be diagnosed with mild cognitive impairment or with dementia. So because of this, we're actually quite interested in looking at how lifestyle factors may help to prevent further cognitive decline. I'll be talking about two of those lifestyle factors in just a little bit. Now, it's also important to note that other conditions such as stroke are also substantially related to our cognitive health as well. For instance, stroke actually doubles the risk of dementia and cerebrovascular diseases, such as stroke are the second most common cause of dementia, specifically vascular dementia, which accounts for up to about 40% of all dementia cases. Importantly, stroke-related cognitive deficits are also associated with other negative outcomes, including institutionalization, reduced quality of life, and increased mortality risk. And while stroke survivors represent a target population for intervention to promote cognition and prevent dementia, the current standard of care in stroke rehab does not adequately address the clinically important cognitive consequences of stroke, particularly among those who are in the chronic phase of stroke. Now, there are a number of different reasons for why individuals with stroke end up being diagnosed with dementia. I'm not going to go over all of these in detail today, but broadly, these include things such as demographic features, such as age, education level, and things like that. It can also be based on where the stroke occurs and what type of stroke occurs. There can also be neurological characteristics that are related to the stroke in terms of things like cerebral atrophy, and what type of aspects of the stroke are happening, including things like white matter hyperintensities. And then in addition to these things, we also have to keep in mind that there are modifiable risk factors that may be related to stroke and also may be related to dementia as well, including things like hypertension and also lifestyle factors as well, such as physical activity and sleep. Now, broadly, the way that I like to think of these lifestyle factors is I like to consider these all time use activity behaviors, and I'll explain what I mean by that in just a moment here. So broadly, time use activity behaviors refer to behaviors such as physical activity, sleep, and sedentary behavior that make up the approximate 24-hour day. And each of these behaviors are related to each other through the circadian cycle, which, as Jason mentioned just a moment ago, is the roughly 24-hour biological clock, which helps to regulate our sleep-wake cycle with the solar light-dark cycle. In addition, these time use activity behaviors are energy independent, meaning that they have different energy expenditures. So for instance, sleep has an energy expenditure of about 0.9 metabolic equivalents, or slightly a little bit less than our resting energy expenditure when we're awake. Whereas physical activity has an energy expenditure of greater than 1.5 metabolic equivalents. That is 1.5 times our resting energy expenditure. And we're not going to talk about sedentary behavior today, but what that refers to is it's any waking behavior that's done while sitting, and that incurs less than 1.5 metabolic equivalents. These behaviors can also be dichotomized by whether they are done while awake or whether they are done while sleeping. So let's talk a little bit more about what physical activity is. As I just mentioned, physical activity refers to any bodily movement which increases energy expenditure above 1.5 metabolic equivalents, and broadly can be broken down into 4 different categories. That is occupational physical activity, or things that we do while we're working; transportational physical activity, which refers to how we get from place to place; household physical activity, which refers to household chores like sweeping, vacuuming, things like that. And then finally, leisure time physical activity, which refers to anything that we choose to do in our own time, such as, whether it's skiing, snowboarding, or something that we do for fun. And then as a subcategory of leisure time physical activity, there's exercise training, which refers to any planned physical activity for the purpose of trying to increase or maintain physical fitness. Now, we can also classify physical activity based on the intensity at which it's done, with light physical activity referring to physical activity that is between 1.5 and 2.9 metabolic equivalents, and then moderate to vigorous physical activity being anything above 3 times our resting energy expenditure. So sleep is obviously a little bit more complicated and difficult to define, but broadly what sleep refers to is it's a rapidly transitionable state that is characterized by its immobility. And broadly, there are 2 different types of sleep that we can classify. There is psychological sleep, which refers to the perceptions and attitudes, the behaviors, and the mental characteristics that make up our sleep. And then there's also the physiological processes that make up our sleep, both in terms of hormone regulation, recovery processes, and things that Jason mentioned just a little while ago, as well as the basic underlying structure that makes up our sleep, including things like REM sleep, as well as non-REM sleep, which can be categorized into increasing stages of depth, with stages 3 and 4 making up what is termed deep sleep. So in terms of how we can measure sleep in a research setting, one way of doing that is using something called wrist-worn actigraphy, which is a device that's worn on the non-dominant wrist for approximately 7 days. And we can measure both physical activity and sleep quality using this device. And it's quite beneficial because we can use it to check out how people are moving throughout the day. And then we can also measure, or at least get a basic estimate of how somebody is sleeping as well throughout the course of the night, since they should be relatively immobile throughout the course of the night. Of course, one of the downsides to using wrist-worn actigraphy is that we're not going to be able to get things like EEG or polysomnography type measurements using wrist-worn actigraphy. So there are certain things that we're not going to be able to get, but we can at least get basic estimates of both behaviors in an objective manner. So now that I've filled you in on how what these behaviors are, let's talk about how these behaviors are related to each other and also related to cognitive health. So in terms of the evidence right now about how physical activity is related to cognitive health, as I'm sure most of us are aware, physical activity is associated with better cognitive abilities, and it's also associated with a lower risk of dementia. We also see that from experimental studies that exercise training can improve cognitive function, and it's also associated with better brain health as well. We also see from observational evidence that poor sleep is associated with an increased risk of dementia. And from experimental studies, we find both in animal models and in human models that poor sleep is associated with poor cognitive health. And from sleep restriction studies, meaning when we force people to not sleep throughout the course of the night, we actually see that cognitive performance is worse. And we also find that brain function is worse as well. In terms of how physical activity and sleep are related to each other, the evidence suggests that it's actually a bidirectional relationship, meaning that physical activity can influence better sleep, but we also see that sleep can also influence next day's physical activity as well. And we also see from experimental evidence that having somebody exercise can actually improve somebody's sleep, although the evidence seems to suggest as well that as we get older, the effects of exercise on sleep tend to weaken with age. And then finally, the relationship in terms of the pathway by which physical activity and sleep may impact cognitive health is not really clearly defined at this point. And what we seem to see is that physical activity may both moderate the relationship of sleep with cognitive health, meaning that it may help to influence better cognitive health regardless of how somebody is sleeping, or it might also maximize better cognitive health if somebody sleeps better. But we also see that better physical or higher amounts of physical activity may also improve sleep quality, and that in turn may also promote better cognitive health as well. So as yet, we're not really sure how these behaviors are related to cognitive health, but we're at least aware that they do influence each other and they also influence cognitive health as well. So what I'd like to next do is I'd like to just talk with you about two studies that we've done looking at how physical activity and sleep quality, how physical activity may actually influence sleep quality. And the first study was looking at whether physical activity promotion in conjunction with bright light therapy and sleep hygiene education could also improve sleep among older adults with mild cognitive impairment. And for this study, what we did is we recruited participants between 65 and 85 years with probable mild cognitive impairment and poor subjective sleep quality. And we performed a baseline assessment of both their sleep quality objectively using wrist-borne actigraphy. And then we also included a questionnaire called the Pittsburgh Sleep Quality Index, which can measure subjective sleep quality as well. And then following this, we then randomized participants to either a personalized chronotherapy group or a usual care control group. For the first 4 weeks of the study, we provided once weekly sleep hygiene education, which followed some of the components that Jason was mentioning earlier in terms of things like practical advice about like avoiding the bedroom unless you are planning to sleep or have sex. And then also including other aspects as well about, trying to get bright light, trying to be more physically active and things of that nature as well. During that first 4 week span, we also provided optional weekly health enrichment lectures for the usual care control group. During the next 20 weeks of the study, we then provided a personalized bright light therapy program, which I'm happy to explain about later, but I won't right now for the sake of time. And then we also provide a personalized physical activity promotion program as well. And we monitored individuals' physical activity using a Fitbit Flex. And then we tried to make sure that we could follow and change the physical activity promotion program as needed in order that all participants were eventually reaching 150 minutes per week of physical activity. During that same 20-week span, the usual care control group received monthly phone calls where we asked them about their general well-being, quality of life, and things of that sort. But there was nothing else that we did beyond that. We then followed up with participants at 12 and 24 weeks follow-up, with the final assessment occurring 24 weeks after. Okay, in terms of the actual analysis itself, our primary question was whether the personalized chronotherapy program could improve objectively measured sleep efficiency. And what sleep efficiency refers to, it's the amount of time that somebody spends in bed actually sleeping versus the amount of time that they spend in bed trying to sleep. As a secondary aim, we looked at whether personalized chronotherapy could improve other aspects of objective and subjective sleep quality. And we use the same methods as you can see above. And so the other objective estimates I will just briefly mention: sleep duration, obviously that's how long somebody spends sleeping. Fragmentation index refers to how much somebody is moving around while they're sleeping. And sleep latency is how long it takes somebody to fall asleep after they first start trying to sleep. And wake after sleep onset is the amount of time that somebody spends in bed awake after they first start sleeping. Okay. In terms of the participants themselves, they were approximately 70 years of age, roughly split between male and female. And then in terms of their physical activity, as you can see here, at least from their self-reported physical activity, they were all quite active at baseline, getting about 9 hours of physical activity per week, at least according to the CHAMPS physical activity questionnaire that we used. We also found that these participants were actually having pretty good sleep, at least according to our objective estimates, getting about 80% sleep efficiency each night, and sleeping roughly somewhere between 6 and 7 hours of sleep each night as well. However, as you can see, our participants were also reporting pretty poor sleep quality, at least subjectively. So in terms of the results, we actually didn't find that there was any effect of the intervention at either 12 or 24 weeks on sleep efficiency. And we also didn't find that there was any effect of the intervention on any secondary outcome of objective sleep quality. However, we did find that following 24 weeks of the intervention, that that subjective sleep quality did improve in the intervention group compared to the control, with about a 1.5 point improvement relative to the control. And then we also didn't find that there was any effect of the intervention on cognitive performance. And we, interestingly enough, we also didn't find that there was any change in physical activity level as well. And as I mentioned before, these participants were pretty active at baseline. So we weren't that surprised that there wasn't that much of a change in terms of the physical activity level. So based on these results, we can conclude that physical activity promotion in conjunction with bright light therapy and sleep hygiene education improves some aspects of sleep quality in older adults with mild cognitive impairment, but we can't necessarily determine which aspect of the intervention is actually leading to changes in sleep quality. Okay, so secondly, I'd like to just briefly talk about another intervention that we just completed, looking at whether exercise training can improve sleep quality in older adults with chronic stroke. Now, the reason that we did this is we previously had conducted a study looking at differences in sleep between individuals with chronic stroke and those without chronic stroke. And we had these individuals age and sex match, meaning that they were the same age and the same sex for each individual. So there were the same number of males and females in terms of those who had stroke and those who did not. As you can see here, individuals with stroke had pretty poor cognitive performance as compared to those without stroke. So an ADAS-Cog plus score that is positive is indicative of somebody that has mild cognitive impairment to dementia, while a negative score is indicative of somebody that has cognitive performance that's indicative of healthy cognition. We also found that individuals with stroke had substantially longer subjective sleep duration than individuals without chronic stroke. And we also found that individuals with chronic stroke also had a longer objective sleep duration than their healthy cognitive counterparts. And individuals with chronic stroke also had more sleep fragmentation as compared to individuals without stroke. Importantly, what we also saw as well is that for individuals with chronic stroke, that there was a interaction effect wherein individuals with chronic stroke and poor sleep, there was actually a greater discrepancy in terms of their cognitive performance as compared to individuals without with better sleep quality. So individuals who had better sleep quality and had chronic stroke, there was less of a discrepancy between their healthy cognitive counterparts, which seems to suggest that if we can promote better sleep quality among individuals with chronic stroke, this might actually be beneficial for helping to maintain their cognitive health. So as a secondary outcome from a recently conducted proof of concept randomized control trial, we were actually interested in looking at whether 6 months of exercise training or social and cognitive training on cognitive function could improve sleep in individuals with chronic stroke, that is greater than 1 year since stroke incidence. And for the study, there were 3 groups: a twice weekly exercise training group, a twice weekly social and cognitive enrichment program, and then a twice weekly balance and tone control group. And this trial was just recently completed in August of 2019. And as you can see here, there were 120 individuals roughly who were involved in the study, and we randomized them as you can see above. And the objective and subjective sleep measures were the same as the trial that I mentioned just a moment ago, and this was a 6-month trial. Okay, so in terms of the number of participants that completed the trial, there were 103 participants that completed our trial in total, 46 in the balance and tone group, 29 in the social and cognitive enrichment program, and 28 in the exercise group. In terms of the participants themselves, they were roughly 70 years of age at baseline, and substantially more females than males, and which was interesting in its own way. And we also found that there was also a low number of individuals who had obstructive sleep apnea in this group, which is quite interesting, since sleep apnea is quite common in individuals who have chronic stroke. So surprisingly enough, not many individuals actually report obstructive sleep apnea. And then in terms of their sleep itself, they had a sleep duration of roughly 7 hours per night, and relatively good sleep efficiency overall, which was, again, quite surprising given the sample itself. However, their subjective sleep quality was what we would consider to be poor at baseline, with a Pittsburgh Sleep Quality Index score of approximately 6 or greater, being indicative of poor sleep. In terms of the primary results of this trial, we found that the exercise training group significantly improved in cognitive performance relative to the balance and tone control group. However, in terms of our results for sleep, we actually found that there were no significant differences between intervention groups and the balance and tone group for any objective measure of sleep. Interestingly enough, though, we did find that the social and cognitive enrichment program did significantly improve in their subjective sleep quality relative to the balance and tone control. However, there was no significant effect of exercise versus the balance and tone control group. Although in terms of the sample size, it was relatively small, but we did see a positive direction in terms of the differences between groups. So in terms of the results of the study, what we can say is that at least based on our preliminary results, that physical activity in the form of exercise training does not appear to substantially improve sleep quality in older adults with chronic stroke. And so I'd just like to highlight a few limitations just before I leave my time. And those being that, again, we're using actigraphy in individuals with chronic stroke. And, obviously those individuals might have some movement impairments, and thus we might not be getting accurate estimates of their physical activity and their sleep. Again, our obstructive sleep apnea diagnosis was actually done retroactively. So we were asking them if they had been diagnosed with obstructive sleep apnea rather than actually performing a sleep apnea test. And then we're not really sure of the role of sedentary behavior for any of these studies, at least at the moment. And, there is a difference in terms of physical activity, which is sporadic in nature and doesn't necessarily happen all at one time versus exercise training, which is planned and usually is done for physical fitness. And then finally, lastly, the complexity of sleep is also something to consider as well, seeing how, we are talking about a very complex behavior in nature. And then lastly, before I go, I'd just like to acknowledge the members of the Aging, Mobility, and Cognitive Neuroscience Laboratory, as well as my supervisors, Dr. Teresa Lou Ambrose, and then also Dr. Karen Khan. And I'm happy to take any questions now.
That's excellent. Thank you so much, Ryan. Really appreciate the talk. So with that, I would like to pass it off to Elaine Book.
Hello, everyone. So one of the advantages of coming in the cleanup position of a panel is that some of the content has already been shared, but for me, I always learn best by hearing things a few times. And so you may hear some of my tips and tricks that you've heard from Dr. Valerio or from Ryan as well. And, when I started thinking about doing this talk, I've been working from home and my dog Oscar is living his best life because I am working from home, and he is sleeping all around me in a variety of different positions at different times. And so I really kind of designed this talk with his help, actually. So top 10 tips and tricks to help with sleep. First one, maintain a regular sleep routine. So really wake up at the same time, go to bed at the same time. That should really stay within kind of 20, 30 minutes, 7 days a week. Same kind of bedtime and wake time, ideally. Tip 2, avoid daytime naps. Okay, Oscar really does not listen to this tip. So really though, if because of your health condition, you do feel like you do need to take a nap, just try and take that nap earlier in the day, and certainly, for a shorter period of time, kind of a 30-minute power nap is usually acceptable. But I think the key thing is earlier in the day. Tip number 3, do not stay in bed awake for a long time. So, if you find that you get into bed and your mind is racing or you're worrying about things in the middle of the night, get out of bed, go and sit in a chair in the dark, do that mind racing there until you're sleepy, and then return to bed after that. So no, don't go to the TV, don't go to the internet, none of that during this period of time, because that's only going to stimulate you. Tip number 4, don't watch TV or work on the computer like a laptop or read in bed. That when you watch TV or read in bed, you're really associating wakefulness while you're in bed. And that blue light that we heard about really can adversely affect your circadian rhythm. And so you can, Dr. Valerio, I think, was talking about some lights that you can purchase at the store in terms of wakefulness, but there's also blue light blocking kinds of glasses that you can use 2 hours before bed, and that has been shown to improve quality of sleep. And just that reminder that bed is, really reserved for two things: for sleep and for intimate relations. Tip number 5, caffeinate with caution. This is a picture where you would think that my dog has just had a whole whack of caffeine because he was all excited and happy. So if you're going to consume caffeine, do it before noon. Remember that caffeine is in coffee, it's in soda, it's in tea, it's in chocolate, hiding in all of these different places that you may not recognize. You're getting caffeine. Tip number 6, be mindful of substances. So cigarettes, alcohol, over-the-counter medication, cannabis, all of those things can work against you and can cause some difficulties with sleep. Tip number 7 is that clean, fresh air. So Dr. Valerio talked about a cooler temperature, so consider cracking open a window a little bit. If that doesn't work for you, because you don't like to be cold, you can even just try an air purifier to keep the airflow and the air in your room fresh. Exercise. So we've just heard a lot about exercise. I think there was a question in the chat about when is a good time to exercise. So for my reading, and the others can chime in on this as well, but certainly if you're able to exercise before 2 in the day, or certainly not right before bed, because that vigorous exercise can stimulate endorphins and other things in the body that might cause it difficult to fall asleep. Of course, being mindful that regular exercise promotes sleep. So it's just about when you do it. Tip number 9, create that quiet, comfortable bedroom environment. So the cooler temperatures, the no TV. If your pet is in your room and is prone to making noises through the night, you might want to consider moving the pet out of the room. Minimize any sources of light that might be coming from outside of your, through a window. So you want a dark room. And if you have a bed partner who snores, maybe consider looking at some snoring remedies of the partner. Finally, tip number 10, those calming rituals and bedtime routines. So you can do all of these things to maintain good sleep hygiene, but sometimes that's not always enough. And we might need to establish some good bedtime routines. So we heard about a warm bath or a shower, but other things might include some meditation practice or some mindfulness activities, progressive relaxation. Progressive muscle relaxation is another really calming kind of effect. It's kind of where you start at the top of your head and work your way down, where you tense and release your muscles as you go, and it's been proven to be quite effective in relaxing. Breathing exercises as well. So something as simple as breathing in for the count of 5 seconds, holding it for 5 seconds, and breathing out for 5 seconds, and repeating that for a couple of minutes can be quite effective as well. Essential oils like lavender and chamomile, those scents and flavors have been known to be calming and soothing. And my 95-year-old mother swears by warm milk before bed. And I think that there is something in milk that has like a sleep-inducing factor in it. Some people even have considered putting, I think it's nutmeg, a spice of nutmeg that is been found to be helpful for inducing sleep. And lastly, here's just a couple of resources if you wanted to find some other tips and tricks about sleep hygiene. I've got 2 apps, Calm and Headspace, that are available, that are mindfulness and meditative types of apps that you can use. And the last one there is a book, which Dr. Valerio recommended to me a few years ago, and has been quite helpful for people as well. Thank you.
Excellent. That was very helpful, Elaine. We'll post those resources on our webpage as well as the recording of this video. So please feel free to check those out. We do have 2 minutes left before the top of the hour here for a couple quick questions. I know Dr. Falk has answered a couple of the questions in the chat already, so thank you very much for that. A couple of the questions that came up, and this one might be for Dr. Valerio. Are there any foods that you can have before sleep that might help with sleep? So I know Elaine talked about milk. Are there any other maybe foods that could promote sleep?
There's not typically anything that I would recommend right before sleep. If you do have to eat before sleep, then like I said, have a proteinaceous meal. Usually you actually want to avoid eating directly before sleep. So eating itself is actually an alerting behavior. So I would kind of separate those in time just a little bit. But again, if you have to have that evening snack, just avoid carbohydrates and refined sugars. That would be my recommendation.
Sounds good. And there's another question about cannabis. Are there any thoughts or research done on cannabis to help with sleep issues? Does it help or hinder sleep?
Yeah, so there is some research, but the evidence has been mixed thus far. And it's not really clear, we're still in the very early processes of understanding the effects of cannabis on sleep. So I don't think that there's really a best evidence case for it, and I don't know if we really know the efficacy of cannabis for promoting better sleep, at least in the general population. There might be some specific instances where it can be beneficial, but I'm not that familiar with that line of research and inquiry.
And I agree. I don't think it's been studied extensively. And part of the problem is the different level of and number of cannabinoids that you're dealing with. But if you're looking at THC, there's at least some evidence that it may suppress REM sleep or dream sleep. Again, a little bit controversial and still in its infancy in terms of studying, but you definitely don't want to be suppressing stages of sleep, especially your deep sleep and your dream or REM sleep.
Thank you both for those answers. We are now at the top of the hour, so I want to thank everyone for joining us today. I think this was a very productive talk. I know we kind of blazed through those talks just for the sake of time. So as I mentioned before, they will be posted on our website and on our YouTube channel. The links are also in the chat, so feel free to look out for those. They're usually posted within a week or two from these talks. So if you'd like to rewatch them and get more information, please visit our website. And again, I'll also remind everyone our classes are open for registration across the board. So please feel free to register online for all of our classes. We'll also have a new set of classes being launched on March 29th as well. So please keep your eyes and ears out for that. With that, thank you very much for joining us today and have a wonderful rest of your day. Bye-bye.